low. So amongst these, iron deficiency anemia, if you would be knowing, all three types of thalassemia, whether it is state, which usually has only mild anemia, or it is major or intermediate, in which situation they may have significant blood transfusion requirements and moderate to severe anemia. Anemia of chronic disease, which may be microcytic hypochromic or it may be normocytic normochromic anemia, lead poisoning, sideroblastic anemia, and iron refractory iron deficiency anemia. So remember these causes. Of these, only anemia of chronic disease may also have normocytic normochromic anemia, but rest of them are classical causes of microcytic hypochromic anemia. So if the HB, TLC and platelets are normal and only hemoglobin is low, and you have associated microcytic hypochromic anemia, you should think of these causes: iron deficiency, thalassemias, all types, lead poisoning, sideroblastic anemia, and iron refractory iron deficiency anemia. Now let's look at the first case. A 15-month-old boy was brought with complaints of paleness of body for 1 month, poor appetite, irritability, and pica. His third born to a 24-year-old thinly built mother. Exclusive breastfeeding till 8 months of age, then started on diluted cow's milk 1:1, which was the predominant diet till now. On examination, the child just has pallor, but there is no jaundice, no hepatosplenomegaly, no lymphadenopathy. What do you think this is? Even without the CBC, what do you think this is? Can someone just tell me, reply to me? Any answers? Nutritional anemia. Now specifically from this, do you have any clues which type of nutritional anemia this is? Someone has mentioned iron deficiency anemia. This is a classical history you will get in iron deficiency anemia. In history itself, I'm saying. For 15-month-old, what is the typical age of presentation of iron deficiency anemia? 6 months to 2 years of age. Why? Because this is the time when the children will be put on weaning and the weaning may be inadequate and improper. Now, this child has history suggestive of poor appetite, irritability, and pica. So, pica is something we significantly associate with iron deficiency. See, apart from the typical features of iron deficiency like poor, non-specific features of iron deficiency like poor appetite and irritability, there are 4 things in which iron deficiency is present in a large proportion. These include pica, that is eating of non-nutritional substances. You have children who present with febrile seizures. It has been seen that a significantly larger proportion of these children with febrile seizures have associated iron deficiency. The third is breath holding spells. A significant proportion of children with breath holding spells have associated iron deficiency and anemia. And the fourth one is thrombosis. A large proportion of children with thrombosis have an underlying iron deficiency anemia. So apart from the non-specific findings, these are the 4 group of children specific symptoms which if present should poke you to actually look for an underlying iron deficiency anemia. So he has pica. Now look at the birth history. He's third born. So already third born, the mother already has 2 other children. A 24-year-old thinly built mother. That means the mother herself is malnourished. This itself gives you a clue. The 24-year-old female and she's already having a third child and she herself is malnourished. Now this child has been on exclusive breastfeeding till 8 months of age. That means he has inappropriate weaning. Then started on cow's milk, that too diluted. Now cow's milk, even in my last class I told you, it prevents the absorption of non-heme iron because it has casein, it is rich in casein and whey protein and calcium also. So all this prevents the absorption of non-heme iron. So when they're giving cow's milk and that too in a diluted manner. So all these things on history and towards iron deficiency. Now on examination, iron deficiency anemia is typically characterized by isolated pallor. Pulmonicea, platanicia, something you find very, very rarely. I haven't really seen it till date. And there is no hepatosplenomegaly and lymphadenopathy and jaundice. So no jaundice means very unlikely to be a hemolytic anemia. No hepatosplenomegaly rules out other causes. So on history and examination, this is likely an idea. Now let's look at the blood count. What do you have? You have an HB, which is low for age, PLC, which is normal. What happens to the platelet? So platelet count is slightly increased. What is the usual platelet count? 1.5 to 4 lakhs per cubic millimeter. But in this situation, there is thrombocytosis. Now, why does that happen? Because of iron deficiency, because there is anemia, there is increased production of EPO. And this EPO also acts on the thrombopoietin receptor, which helps in proliferation of the platelets. So that is why EPO also has a TPO-like action, and that is why thrombocytosis occurs. So this particularly is seen in iron deficiency anemia. Absence of thrombocytosis, of course, does not rule out iron deficiency, but presence of associated thrombocytosis points towards iron deficiency anemia. Now, what is MCV? MCV is low. So this is microcytic anemia. MCH is low, hypochromic anemia. MCHC is low, hypochronic anemia. Now, what happens to the RDW? RDW is increased. We said that the upper limit of normal is 14.5%. So, in all sorts of nutritional anemias, the RDW, red cell distribution width, is increased. Okay, whatever you're putting up in your comments, no, I'll answer in the end, okay? All your queries, I'll come back to you and answer them in the end, whatever I need to repeat, okay? So, in all nutritional anemias, the RDW is increased. So, in this situation, the RDW is increased and the RBC count is reduced. So, this is a typical example of iron deficiency anemia. What do you find on the slides? You look at the peripheral smear. Look at this. This is a normal, look at my cursor. I pointed it on a normal lymphocyte. Now, a normal sized RBC is usually as large as the lymphocyte or only slightly smaller, but in microcytic anemia, the RBCs are smaller than the size of a normal lymphocyte. So, look at these RBCs. These are all small sized RBCs. Now, another thing, so this is microcytosis. Now, what second thing you have to look is hypochromia. Now, look at this cursor. In this, look at the central disc of pallor, the whiteness. It is more than 2/3. So, normally only the central 1/3 of the RBC is pale. But in this situation, more than 2/3 of the RBC is pale, and this is hypochromia. This is because there is less amount of hemoglobin in the cell. So, there is microcytosis and there is hypochromia. Now, another thing, you look at the sizes of the RBCs. And you see there are different sizes of RBCs. Some RBCs are small, some are large, some are even larger. So, the range of size of RBCs is significantly high. This means that the RDW is high. That is what we mean by anisocytosis. That is significant variation in the size of RBCs, and that is what leads to increase in RDW. So that is why you see different sizes of cells. And there's something called poikilocytosis. That means different shapes of RBCs. So look at this one. This is a teardrop RBCs. This is a typical spherical RBCs. This is an oval RBCs. This is something of a pencil-shaped RBC. So all sides of shapes of RBCs are seen, and this is poikilocytosis. So iron deficiency anemia is a typical microcytic hypochromic anemia with anisopoikilocytosis, and leukocyte and platelet morphology is usually normal. So look at these platelets. These platelet morphology are normal. These are the platelets. Look, here the cursor. These are the platelets. So these are normal platelets. This is a normal lymphocyte, and RBCs are normal. So we ran a serum iron profile on this child. Serum ferritin is reduced, transferrin saturation is reduced, BC is increased, and serum iron is reduced. This is a diagnosis of iron deficiency. Now let's come to case number 2. So a 12-year-old girl was brought with complaints of cough and coryza for 2 days. This I saw only in my last OPD. And on examination, incidentally, we saw that she had mild pallor, but she did not have any jaundice, no hepatosplenomegaly, no lymphadenopathy. There is no history of worm infestation, bleeding for any site, and dietary history is adequate, no significant family history, and thermometry is normal. She is SMR stage 3, so she is still not attained menarche. So if I would, think think in terms of that she might be having excessive bleeding through her period. So that is also not so. Now, but her mother says dietary history, when I took the calorie count and the protein amount, that was all fine. But the mother says she's a finicky eater. She's very choosy with what she eats. But it wasn't really significant. Now, what do you think is the diagnosis? Anybody? You have the CBC. Do you think this is iron deficiency? Do you think it's something else? Anybody? Very good. Some smart person has said thal minor, but why not iron deficiency? Why do you think this is not iron deficiency? We have a low hemoglobin. We have a TLC which is normal. Platelet count may be normal in iron deficiency. Now, why should this be a thal minor? Excellent. So you people are answering and you are observant enough to see, although there is microcytosis, there is hypochromia, and there is hypochromia both in terms of MCH and MCHC, but the RDW is normal. So in iron deficiency anemia, we said that the RDW would be increased. Now, remember, in early iron deficiency, there might be a normal RDW, but for your practical purposes, remember, RDW is increased in iron deficiency anemia and all nutritional anemia. So, a normal RDW says, okay, this is microcytic hypochromic anemia, but RDW is normal. Now, what is this with RBC count? Do you think there's a problem with the RBC count? Anybody? Do you think there's a problem with the RBC count, or is it okay to have an RBC count of 6.2 million per cubic millimeter at an HB of 10.1? Anybody? Yes, the RBC count is raised. Do you expect that? Yes, it's high. So normally, another pointer that will show you that this is another pointer that shows you that this is not an iron deficiency anemia is the RBC count. So let's look at something known as the rule of 3. So normally they say whatever is the RBC count into 3 will give you the hemoglobin, and hemoglobin into 3 will give you the hematocrit. So if you look at her RBC count, we would have expected that her hemoglobin should be somewhere around 18. That sounds very weird. So we know that this RBC count is definitely higher. So this is something that you see in thalassemia minor, not in thalassemia intermedia, not in thalassemia major. So remember, this RDW is normal only in thalassemia trait. If you talk of thalassemia intermedia or major, your RDW is going to be increased. Likewise, the RBC count. RBC count is increased only in thalassemia trait, not in thalassemia intermedia or major, because in those situations, within the bone marrow itself, the RBCs are destroyed. The precursors itself are destroyed. So there is no increase in RBC count because there is ineffective erythropoiesis in intermediate and major. This is one different thing. Normally in any anemia, RBC count into 3 is hemoglobin, hemoglobin into 3 is hematocrit. But in thalassemia, this rule of 3 is not followed, thalassemia minor. And that is why we diagnose this child as thalassemia trait, possibility of thalassemia trait. Of course, we have to confirm it by doing an HPLC. So what is the Menzel's index coming from that? MCV by RBC count. So MCV is low in both thalassemia trait as well as iron deficiency anemia. But the RBC count will be proportionately decreased in iron deficiency anemia. So the Menzel index would be more than 13. Whereas in thalassemia traits, the MCV is low, but the RBC count is increased. So when the denominator increases, the dividend comes to be less than 13. So Menzel's index less than 13 is suggestive of thalassemia trait, and more than 13 is suggestive of iron deficiency anemia. But remember, this is useful only for differentiating thalassemia trait and IDA, not for thalassemia major or intermediate. And from that, I'll come to the second point. Can a thal major or intermediate have iron deficiency? Anybody? Can a thal trait have iron deficiency anemia? Hey guys, are you there? Can a thalassemia trait have iron deficiency anemia? Yes, a thalassemia trait can have an iron deficiency anemia, right? But in that situation, how will you differentiate? So this is purely a thalassemia trait. However, if it had been thalassemia trait with iron deficiency anemia, the RDW would have been increased. RBC count would also have been increased and RDW would have also been increased. That is how you can differentiate between a pure thalassemia trait and thalassemia trait with iron deficiency anemia. But does thalassemia major and intermediate have iron deficiency? Anybody? Can thalassemia major and intermediate have iron deficiency? Any answers? No. So intermediate and major will not have iron deficiency. They are states of iron excess even without any blood transfusion. Yes. So even if the child has received no blood transfusion in thalassemia, intermediate and major, they are still in a state of iron excess, and therefore there is no business of differentiating IDA with thalassemia major or intermediate. So this is the slide of thalassemia trait. You again have microcytic hypochromic anemia, but can you see the size of the cells is near about similar. There is not much difference in the size of the cells. So there is minimal anisocytosis, whereas in IDA, the size of the cells was very variable. And also look at how closely packed this RBC is. Look at over here. They're almost forming a rouleau. They're so closely packed because the RBC count is increased. This is what happens in thalassemia trait. So we did an HbLC. The HbA was normal. The HbF was normal, but the HbA2, that is the catch here. Normally HbA2 is less than 3%, and in thal trait it is between 3 to 8%. So her HbA2 was around 4 to 5%, and that's how we made a diagnosis of thal trait in this girl. Now let's go to the next case. So 6-month-old boy was brought with complaints of paleness of body for 1 month and abdominal distension for 1 month. This child is a firstborn to a 25-year-old healthy mother, and he's been adequately fed. History of anemia is present, requiring blood transfusion in maternal aunt. On examination, this child has pallor, but there's no jaundice. There is splenomegaly 5 centimeters and hepatomegaly 2 centimeters. Someone has already said thal major. Can you tell me why? Can you tell me why? The pointers towards thal major. Anybody? So, yes, the first month is age. At 6 months of age, it is very unlikely that a child presents with a severe anemia having an HB of 6.5. Nutritional anemias usually present beyond 6 months to 2 years, between 6 months to 2 years of age, and not just at 6 months with such severe anemia unless the mother is severely deficient herself. But that is something rarer. Now the second pointer, he is firstborn and to a 25-year-old healthy mother. So we know the mother is actually very well, is adequately fed. Third is there is a family history. So family history of blood transfusion in a maternal aunt. Think of child having some hemoglobinopathy. 6 months age, 3 to 6 months of age, first presentation with anemia is a pointer towards hemoglobinopathy. Lastly, why should a nutritional anemia have splenomegaly and hepatomegaly? That again is a pointer that this child probably has some hemoglobinopathy. So now we have the complete blood count, 6.5, 4,700, platelet of 1.4 lakh. Microcytic hypochromic anemia with RDW increase. Now if you don't look at the examination properly and you would just look at this CBC, someone might just pass it for iron deficiency anemia. But that's the catch. That is why the history and examination is equally important. CBC, in the CBC you may think this is iron deficiency, but if you had not taken a proper history or missed the hepatosplenomegaly, you would have started treating this child as an iron deficiency. Most of the times, I don't think you guys miss it at this primal level. So the possibilities are thalassemia major, thalassemia intermediate. Now we did a serum iron profile, the serum ferritin was raised, transferrin saturation was increased, serum iron was increased. Idea is of course out of the window, and anyways we thought that this is likely to be a thal major. Now look at the slide of thal major. What do we see? So again, microcytic hypochromic anemia. So the RBCs are smaller in size. There is a significant degree of anisopoikilocytosis, different sizes and different shapes of RBCs. When you look at these red arrows, these are the nucleated RBCs. So someone is asking why was the RDW raised? So I told you in thalassemia major and intermediate, the RDW is increased because there is a significant degree of anisocytosis. The RBC sizes are significantly different. Whereas in thal trait, the size of the RBCs are nearly the same, so RDW stays the same. Now, in these, the red arrows are the nucleated RBCs which have been released prematurely from the bone marrow. And this particular RBC is showing this Howell Jolly body, which is this peripheral dot of hemoglobin which is present on the surface of this RBC, which is often seen in these cases with thalassemia major. Overall, it's a very dirty slide to look at. You look at a thalassemia major slide and it looks like a dirty slide, as if everything is out of place, nothing seems normal amongst the RBC. The HPLC was sent for this child and HbA was absent. The normal hemoglobin form was absent. Almost the entire hemoglobin fraction was HbF, 97.6, and HbA2 was 4.5%. So it confirmed the diagnosis of beta thalassemia major. Now let's come to the fourth case. A 9-year-old girl was brought with complaints of failure to gain height and weight over 2 years. There's no history of loose stools, vomiting, fast breathing, jaundice, or any other complaint. Dietary history is adequate. There is no significant family history. Anthropometry-wise, the height is at -3 standard deviation, so she is short stature, and the weight for age is also -2 standard deviation. So she is underweight. Now, examination reveals pallor. There is rickets present in this child. No jaundice, no hepatosplenomegaly, no lymphadenopathy, nothing, right? So now what do you think? And there is dietary history is adequate as per this person. Now what are the differentials? So hemoglobin is 8.8, ALC is 9200, platelet is normal. So only the HB is reduced. MCV is normal to slightly low, so normocytic to microcytic anemia. MCH and MCH is also low normal, so lower part of the normal. So normocytic to normochromic to hypochromic, and RDW is slightly raised. The RBC count is proportionally reduced. Yes, so a lot of you have guessed the cause in this situation. But would this be iron deficiency? If you fail to the anthropometry, see, in these cases, I'm actually giving you everything on the platter, all clues possible in the case I'm giving you in the history and examination, so you can make the diagnosis. But remember, when you're sitting in the OPD, it's your job to actually bring out that history and do that examination. If you miss the anthropometry and you fail to identify that this child is also short stature, she is underweight, he has rickets along with pallor, there is no jaundice, hepatosplenomegaly, lymphadenopathy, you will not be able to make the diagnosis. So all these components, many of you have pointed out the correct diagnosis. But you think this is iron deficiency? Could be, but why is the RDW not so raised? The MCV, MCH are just borderline. It could be, but should we be ignoring the anthropometry? Should we be ignoring the rickets? Should we be ignoring the failure to gain weight and height? So serum iron profile we did, the ferritin was actually raised, the transferrin saturation is reduced, the IBC is reduced, and serum iron is low. Why should the ferritin be high? And that is the red marker again, because the possibility was IDA. Now kidney function tests were done and they came back, and this child has a urea of 136, creatinine of 4.3, Anthropometry showed short stature and underweight, which we already mentioned. Of course, most of the times we are missing the blood pressure in the OPD. Had you taken the BP, there was hypertension. In the first case, this would have been picked up as a case of CKD. The rickets was due to the CKD. So this is a normocytic normochromic anemia or mildly microcytic hypochromic anemia of chronic disease, secondary to a chronic kidney disease. So this is actually anemia of chronic disease. So focus on your history and examination as much as you focus on your TBCs. Now, this is a slide which helps you differentiate between IDA, thalassemia trait, and anemia of chronic disease. Till the red part, actually the slide is meant to differentiate between IDA and thal trait. So look at these red parts only, because HB, NCD, NCH, and MCHC would be decreased in both thal trait and IDA. RDW would be increased more than 14 or 14.5 in IDA, whereas it will be normal in thalassemia trait. So RBC count would be decreased in iron deficiency anemia, whereas RBC count will be increased in thalassemia trait. Menser's index is less than this I've missed the arrow wrong. Menser's index is more than 13 in iron deficiency anemia, whereas in thalassemia trait the Menser's index is less than 13. Now the second lower half of the slide is to differentiate between iron deficiency anemia and anemia of chronic disease, green parts. So serum iron will be low in both iron deficiency and may be low in anemia of chronic disease. When you talk of transferrin saturation, it is significantly low iron deficiency anemia, whereas it may be normal to slightly low in anemia of chronic disease. When you talk of ferritin, because it is an acute phase reactant, it is increased in anemia of chronic disease, whereas it is decreased in iron deficiency anemia. So the next marker that we know of which differentiates between anemia of chronic disease and iron deficiency anemia is serum hepcidin, which is decreased in iron deficiency anemia and increased in anemia of chronic disease. So this is actually beyond interpretation of CBC, but since we have touched upon it, just remember, based on the transferrin saturations, the serum ferritin and serum hepcidin, you can differentiate between a pure anemia of chronic disease and iron deficiency anemia. Now next, so we have discussed till now microcytic hypochromic anemia. Next few cases are about macrocytic anemias, that is a higher MCV. So when you look at anemia, the next point is MCV. Hypochromic, we've discussed microcytic, now we're discussing about macrocytic. If on a peripheral smear, to see macrocytic anemia with hypersegmented neutrophils. So this hypersegmented neutrophils means that there are more than 5 lobations of the nucleus. That means this is likely to be B12 folate deficiency. So if it is a yes, you go ahead and do a B12 folate levels, which is likely to be low, and you label it as megaloblastic anemia. Remember, megaloblastic is actually a term used for bone marrow findings in B12 folate deficiency anemia. On the peripheral smear, you can just call it a macrocytic anemia, right? However, if you do not find any hypersegmented neutrophils, you go ahead and do a reticulocyte count. If the reticulocyte count is low, think of liver disease, think of hypothyroidism, and think of bone marrow failure syndrome. So these are the diseases in which there will not be a compensatory increase, significant compensatory increase in the reticulocyte. Whereas when you have macrocytic anemia with a raised reticulocyte count, think of hemolytic anemias and hemorrhage. Now you test for hemolysis. What are the tests for hemolysis? You look at the bilirubin. There is indirect hyperbilirubinemia. Second, the LDH would be raised. Third, serum haptoglobulins would be low. These are the tests for hemolysis. So if someone has written DCT in the window, to differentiate whether this hemolytic anemia is autoimmune or not, That is why you do a DCT. DCT positive means there is autoimmune hemolytic anemia. If DCT is negative, it may still be a hemolytic anemia. If there is indirect hyperbilirubinemia, LDH is raised and serum haptoglobulin is low, but it will not be autoimmune. Right? So the tests for hemolysis are LDH, which would be increased, indirect hyperbilirubinemia, usually to the tune of 3 to 4 of total bilirubin, milligrams per deciliter, and third is decreased serum haptoglobulin levels. If the test for hemolysis are negative, then this is likely be to a hemorrhage. So let's come to the next case. You've got it. Look at the MCV high. Think of either B12 folate deficiency, in which situation on a peripheral smear you will find a hypersegmented neutrophils. If there are no hypersegmented neutrophils in the peripheral smear, after your MCV, look at your retic count. If the retic count is increased, think in terms of hemolytic anemia. Right? If your retic count is low with a macrocytosis, think in terms of liver disease, hypothyroidism, or bone marrow failure syndromes. Okay. So now let's look at number 5. A 9-month-old girl was brought with complaints of illness of body for 1 month. Dietary history inadequate, delayed weaning, and diluted oats milk intake. There is no significant family history. Mild developmental delay, anthropometry height for age is -2 standard deviation, weight for age is -2 to -3 standard deviation. There is pallor, knuckle hyperpigmentation, no jaundice, no hepatosplenomegaly or lymphadenopathy, no dysmorphism. So even from the history itself, we have such typicalities in the history that we know that this is likely to be a B12 folate deficiency anemia. Now, specifically, I'll focus age. Again, 9 months to 1 year is the typical age when B12 folic acid deficiency anemia presents, usually due to inadequate weaning and prolonged milk intake. Goat's milk, what is the problem? It is deficient in folate. Often folate deficiency is seen in goat milk intake. Mild developmental delay again happens in B12 deficiency. Anthropometry being low is again a pointer towards the poor nutritional intake of the child. Pallor and knuckle hyperpigmentation. Pallor obviously is because of anemia. Knuckle hyperpigmentation is a typicality seen in B12 deficiency anemia. Now look at the complete blood count. Hemoglobin is low. TLC is low. Platelet is also low. So there is pancytopenia. So this can be present in B12 folic acid deficiency anemia, but this can also be present in bone marrow failure syndromes or acquired aplastic anemia. Fine. So but your history is so typical that you know this is going to be B12 folic acid deficiency anemia. Otherwise, had this history not been so typical, there was no delay, weaning was adequate, and knuckle hyperpigmentation you're not able to make out because the child is dark skinned. In that situation, a bone marrow failure, inherited bone marrow failure syndrome becomes a legitimate diagnosis for you people. Now, what is the MCV? It is increased. What is MCH? Normal. MCHC is decreased, so there is some degree of hypochromia, and RDW is significantly increased. So again, all sorts of nutritional anemias. Now, if I would say that this history is not present and it is not typical, and your RDW is increased, can you just give me a moment? Sorry. So, if your RDW is significantly increased, think in terms of nutritional anemias. Then your RBC count is also low. How do you differentiate? So, what is the third diagnosis you could have had? You could have had a hemolytic anemia. Even in hemolytic anemias, your MCP would be increased, RDW would be increased. But what about the retic count? This retic count would be high. So you have to look at things in totality, and why in a hemolytic anemia would TLC and platelets be low? Less likely unless the underlying cause of hemolysis is something like a malignancy or an autoimmune disease. Okay. You got this. You have anemia. You look, there is macrocytosis. When you think of macrocytic anemia, you think in terms of B12 folic acid deficiency anemia. You think of hemolytic anemias and you think of inherited bone marrow failure syndromes. However, in cases of nutritional anemias, your RDW would be increased. In case of hemolytic anemia, the RDW would be increased, but in inherited bone marrow failure syndromes, RDW would be normal. So at this point, looking at the RDW, we have 10 out inherited bone marrow failure syndromes. Now the two differentials that we are left with is B12 folic acid deficiency anemia and hemolytic anemia. Now you look at the retic count, this retic count is low. So again, what is out? The hemolytic anemia limb goes out and your differential boils down to B12 folate deficiency. So this is the slide we see on this peripheral smear. You have a macrovalocyte. The size of the RBCs is larger than the usual and many of them are oval shaped. This is an oval shaped RBC. This is an oval shaped RBC. Another oval shaped RBC. So macrovalocytes. Now look at this neutrophil. Look at the number of lobes in the nucleus. Usually it will have 3 lobes, 3 or 4 lobes. Now in this there are more than 5 lobes. 1, 2, 3, 4, 5, 6, 7. So a hypersegmented neutrophil. It is typical of macrocytic anemia. So retic count is low and leukocyte platelet counts may be reduced. So B12 folic acid level, folate levels were done and came out to be low, and this child was treated as a megaloblastic. Now the next case is 6. An 8-year-old boy was brought with complaints of illness of body for 3 months. There is petechial rash over arms for 1 week. Dietary history is adequate. There is no significant family history. Anthropometry is appropriate. Examination shows pallor. There is a hypoplastic right arm, but there is no jaundice, no hepatosplenomegaly or lymphadenopathy. Again, the CBC is showing pancytopenia. MCV is macrocytic. MC and see, this is just higher side of normal, you would say, just borderline macrocytic. MCH is normal, MCHC is normal, RDW is normal. RBC count is proportionately reduced and retic count is low. Now, so going by the same logic, even if we ignore the history, look just at the CBC count. This is normocytic to macrocytic anemia with a normal RDW with a low retic count. What do you think it is? This is likely to be an aplastic anemia with pancytopenia. And now, when you look at the history, you have a hypoplastic right thumb. The child is 8-year-old boy. This is a very typical finding in Fanconi's anemia. So, the commonest inherited bone marrow failure syndrome is Fanconi's anemia. And often it is found with hypoplastic right thumb. So in someone had also mentioned TAR syndrome. In TAR syndrome, there will be an absent radius, that is classical, and there is thrombocytopenia. So thrombocytopenia is the physical first presentation in TAR. In this situation, there is pancytopenia. So this is likely to be Fanconi's anemia. And Fanconi's children typically present around 8-10 years of age with pancytopenia, with no hepatosplenomegaly, no lymphadenopathy. That is the characteristic feature of aplastic anemia. You have pancytopenia, there is no hepatosplenomegaly or lymphadenopathy, and there is no activity going on the bone marrow to recover because the bone marrow itself has failed. That is why your retic count, RBC count, everything is low. If you would look at the DLC, the absolute neutrophil count would also be very low. And remember, when you diagnose an aplastic anemia, the diagnosis is based on a bone marrow biopsy. Mind you, not an aspirate, but a biopsy. So if you have diagnosed a child as aplastic anemia on a bone marrow biopsy, even if there is no phenotype of Fanconi's anemia, that is the typical hypoplastic thumb, absent thumb, bifid thumb, abnormalities of the radius, abnormalities of the ulna, cardiac abnormalities, genitourinary abnormalities, both failure, developmental delay. Even if none of this is present, you still go ahead and look for chromosomal breakage analysis for Fanconi's anemia, because almost 3 to 40% of children with Fanconi's anemia will not have this phenotypic features and will present straight away with bone marrow failure. So in all cases of aplastic anemia, once you make the diagnosis, first rule out Fanconi's anemia, because the treatments for acquired and inherited bone marrow failures are drastically different, right? So possibility of bone marrow failure was kept, and here we have a referral smear of this particular child. Now this a normal PS for comparison. Look at the cellularity. Can you see how hypocellular it looks? The RBCs are so spaced out. There is only a single neutrophil, and you can't see any platelets. In this particular peripheral smear, look at this cursor. This is a platelet. This is a platelet. This is a platelet. These are all platelets. There are no platelets in this entire slide, and we also have not found any hypersegmented neutrophils to think of B12 deficiency, or blast to think that there is malignancy. Also, we ran an HPLC in which HbF was raised. So, see, HbF is a marker of stress erythropoiesis. So, in cases of aplastic anemia, inherited bone marrow failure syndrome specifically, HbF may be raised. And we did a bone marrow biopsy, and there was a hypocellularity less than 25%. So, we made a diagnosis of aplastic anemia. We did an echo evaluation which suggested a VSD. Of course, we had missed it on examination, and KUB revealed a single knee. So chromosomal breakage analysis was done, which was suggestive of Fanconi's anemia. Then the next case was done. Let's come to the next case. A 3-year-old boy was treated for Plasmodium vivax malaria 5 days back, and on day 3 of discharge developed cola-colored urine. I had history of neonatal hypobilirubinemia requiring phototherapy. Anthropometry is appropriate for this child. On examination, there is pallor, mild jaundice. Liver is not palpable, spleen is not palpable, and there is no lymphadenopathy. Now, we did the complete blood count, and HB is 7, which is low. TLC is normal, platelet is normal. The MCV is slightly increased. The MCH is normal, MCHC is normal. RDW is slightly increased, and RBC count is reduced. Retic count is high. So, what do you think? This is a normocytic to macrocytic anemia with a raised RDW and a retic count high. See, we're giving only three differentials we're trying to rule out for macrocytic anemia. Since the RDW is high, but the retic count is also high, we rule out B12 folic acid deficiency. RDW high, retic count high, with macrocytic anemia, IVF is out. So we boil down to hemolytic anemia. But this be hematuria. Shouldn't we first be doing a urine RM? Of course, a urine RM was done for this child, and there was no hematuria. Platelet count was also normal. But then the resident on duty thought, okay, maybe this is actually vivax malaria only, and the child has not recovered yet, and this might be malaria-associated hemolysis only. But then you look at what all is there. This child has already completed a course of malaria treatment, and the child has no fever currently, no liver, no spleen, which was present at baseline. So now what has actually happened? Yes. So this is not actually infection-induced hemolysis. We did hemolytic markers still, because we know that we were suspecting hemolysis. We did a bilirubin, so there is indirect hyperbilirubinemia. Serum haptoglobulin is decreased and LDH is increased. So these are the parameters which suggest that yes, this is a hemolytic anemia. DCT is negative. So now we know, once we know hemolytic anemia is there, the next step we do is whether this is autoimmune or not. So DCT is negative, this is not an autoimmune hemolytic anemia. We did a urine dipstick and it was positive for hemoglobinuria, suggestive of intravascular hemolysis. So further history revealed that imaquine intake was present for this child as a secondary, agent which is given to prevent further recurrence of this malaria, and G6PD levels were done after 2 months, which confirmed the deficiency of G6PD. So in most places, at least in our center, we are doing a G6PD level before giving primaquine. There are certain drugs which are given in G6PD deficient individuals and lead to an episode of intravascular hemolysis. So you should be careful while giving such drugs in these children. So this is a peripheral smear in this child. Is everybody able to hear me? One of you have written that my voice is
breaking. Loud and clear. Please continue.
Yes, okay. So we have these cells. These are bite cells. These are bite cells. So these RBCs have been eaten. So this is what happens to these bite cells and blister cells when there is only a scraping of the membrane of the RBCs. And then, of course, there are spherocytes and hind bodies which suggest G6PD deficiency. Now, the last part of it, these were examples of macrocytic anemia. Now we come to the last part of it, that is normocytic anemia, where the MCV is normal, and this is actually the most dangerous of all. When you find normocytic anemia, that is when you should be the most scared of what is the underlying cause, because it is mostly sinister. If you get a normocytic normochromic anemia, look at the reticulocyte count. If it is increased, hail, you take a breath because it's likely to be hemolytic, at least you have some positivity. So test for hemolysis again, bilirubin, haptoglobulin, LDH. If positive, think of hemolytic anemia, go ahead, do a DCT. If positive, it is autoimmune hemolytic anemia. If negative, then you think of other hemolytic anemias like a membranopathy, an enzymopathy, or a hemoglobinopathy. Now, if the retic count is normal or reduced, that is when you're scared, because now it may be an anemia of chronic disease, it may be a malignancy like leukemia, it may be a myelodysplastic syndrome, it may be a congenital dyserythropoietic anemia, or it may be an aplastic anemia. So remember, amongst these, anemia of chronic disease may have microcytic, normocytic anemias, and aplastic anemias may present with macrocytic, normocytic anemias. All right. So these are the most sinister causes. When you get a normocytic normochromic anemia with a normal or reduced reticulocyte count, that is when you're most scared, because the differential diagnosis of these are the most sinister of all. So you go ahead, when you have all these differentials, you obviously have to go ahead with the peripheral smear, serum iron studies, and bone marrow examination, which are going to give you the eventual diagnosis. So let us look at the next case. A 9-year-old TDA is congenital dyserythropoietic anemia. So there is significant degree of dyserythropoiesis in the RBCs. Therefore, they keep on dying and do not reach the normal functionality. So a 9-year-old girl presented with pallor for 7 days and had features of CHF. History of fatigue and arthralgias was present since 2 months. There was no history of blood loss, fever, past history of transfusion, and diet was adequate. Anthropometry was appropriate. On examination, she had pallor, mild jaundice, liver was 3 centimeters, spleen 2 centimeters, no lymphadenopathy, alopecia present, oral ulcer present, right-sided pleural effusion. We have bicytopenia, normocytic normochromic anemia, RDW is increased, RBC count is decreased. What would you think? Anybody? Anemia of chronic disease? But what are we missing right now? What are we missing right now? Malignancy, hemolysis. Let's look at the retic count. The retic count is high. So when you're thinking of hemolytic anemia, the retic count would be high. Had the retic count been normal, you would have thought in terms of malignancy. All these features can be present in a malignancy child also. So a single parameter, only this retic count. Had I not mentioned the retic count, there could be a plethora of differentials. Yes, you would have thought of other things, but the moment you think of, you see the retic count, you know, okay, I need to think in terms of hemolytic anemia or hemorrhage. And in this situation, a hemolytic anemia was highly likely. Now, what happened next? This child, we did the hemolytic parameters and we got all the parameters as positive. Now the DCT is also positive. So this child actually, when we did the antibody panel, we found that this child had warm antibody autoimmune hemolytic anemia. Now, what is this business with otherwise this child having alopecia, oral ulcers, right-sided pleural effusions, arthralgias? Some of you have already identified on the history itself. So this child had warm antibody AIHA. A 9-year-old girl, oral ulcers, alopecia arthritis with thrombocytopenia. We did an ANA which came out to be positive. This was a secondary warm antibody AIHA. So warm antibody AIHA may be primary where you do not find the underlying cause, but in this situation we found an underlying cause which was ANA positivity, and this child was diagnosed as SLE based on ULR criteria, started on steroids, got a wonderful response, and is doing very well on ULR. Now the last case for the day, a 9-year-old girl presented with pallor for 7 days and features of CHF, history of fatigue and arthralgia since 2 months, very, very similar to the previous case. There was no history of blood loss, fever, past history of transfusion. Pallor is present, mild jaundice is present, liver is 3 centimeters, spleen is 2 centimeters, and cervical lymphadenopathy is present. Bicytopenia present, normocytic, normochromic anemia. But again, possibilities of malignancies and hemolysis is there, but the red count is normal. So this situation, we did a peripheral smear. Yes, malignancy is the possibility. So peripheral smear revealed a lot of lymphoblasts. We did a bone marrow aspirate and flow cytometry to confirm the diagnosis of DLA, DLL, and the child was started on treatment for the same. So I have taken you through all the cases now to say how we can actually, narrow down on the diagnosis based on history, examination, CBC, RBC indices, and then of course the peripheral smear. So at the end of it, I would say anemia is very common in Indian children. Nutritional anemia is the commonest anemia in children. Whatever you say and do not miss out on the iron deficiency anemias, and do not miss on the B12 folate deficiency anemia. Especially, first of all, do not miss the anemia per se, because we fail to identify mild anemias in most of the cases. Then CBC, RBC indices, and peripheral smear all are to be seen in conjunction to reach a narrowed down diagnosis of anemia. And clinical history and examination are all very, very important. Thank you. Should I be taking the...
I think, first of all, must thank Puneet for excellent, you can say, couple of lectures. That is, taking the basics and then discussing the case history and taking them, tearing them apart, taking them thread by thread, explaining. That is excellent session. And really enjoyed. And this is one of the most common problem we encounter, but we tend to neglect this anemia part. We just investigate, or sometimes don't even investigate, start iron straight away. So the pointers we have given at least make them think, okay, now that I have got a report, and then I will think about it. So you have given them a lot of. So today I think we have exceeded the time, so we have to finish. And before that, let me make an announcement. Am I audible right now properly?
Yes, sir, absolutely.
So those for DCH students, we are finalizing the, how the papers will be divided and all things. We are going to have a meeting soon, but generally the instruction is you are likely to follow National Medical Council diploma course structure. But again, once it is clear, I'll take a demonstration class about the theory and clinical for the first batch of DCH. Probably, I think they have the exams in December, right? So it is for DCH student. In the meantime, again, next class we have got a case discussion on acyanotic heart disease, and thereafter I'll tell again. So once again, Dr. Puneet, thank you so much for the excellent session. So those two combination of lecture. And
thank you, sir. Thank you so much for the opportunity, sir. Thank you.
Thanks, my pleasure. Navneet ji, the chief coordinator, for taking you, for giving us time and coordinating the whole session. And also, dear students, wishing you a happy Dashera and a weekend ahead, nice weekend ahead. Hope to see you again next Friday. All the best. Good night.
Yeah, thank you very much, Dr. Puneet Kaur, for the presentation. And thank you very much, Professor Dr. Shrikanta Basu, for joining. And thank you, trainees and faculty members, for joining the session.